Hello everyone, my name is Nick Jara, and today, July 13th, 2022, I will be presenting you with my case study known as Parkinson's disease today. A typical patient presentation regarding Parkinson's disease can be clearly described here. A 63-year-old male during his yearly physical checkup at his local doctor's office presents with a new onset of resting tremors in his hands, almost pill rolling like. This male also presents with bradykinesia, which is noticed by his wife, along with continuous rigid body stiffness. The physician also notices a sign of postural instability in the patient as he sits down and stands up. Upon further examination, it is also seen that the patient has a loss of smell. The etiology of Parkinson's disease can be best described here as a neurodegenerative disorder. It impacts motor and non-motor functions, so there is a greater prevalence as age increases starting after the age of 40 and an increasing risk at the age of 60 plus. It is a degeneration of dopaminergic neurons, meaning there is less dopamine being made or secreted. This occurs in the extrapyramidal tract of the midbrain, more specifically the basal ganglia, but even more specifically the substantia nigra. The cause of this degeneration in the dopaminergic neurons in Parkinson's disease is unknown, so it is idiopathic. It is said to be a mixed cause of environmental and genetic factors, meaning that a familial factor can cause Parkinson's disease, meaning there is like a gene mutation. There is also an imbalance between acetylcholine and dopamine in Parkinson's. Background information regarding Parkinson's disease can be best described here. For example, a fun fact regarding Parkinson's disease is its name of origin. Back in 1817, a man named James Parkinson wrote an essay describing shaking palsy. Another background fact about Parkinson's disease is that it is the second most common neurodegenerative disease, right behind Alzheimer's disease, which is first in line for the most common neurodegenerative disorder. Parkinson's disease affects around 60,000 to 100,000 people in the United States yearly. So 3% of the population is affected at the age of 65 and 5% of the population is affected at the age of 85. So there is greater prevalence the older you get. 1 million people are affected by Parkinson's disease in the United States currently. 6 million people plus are affected throughout the world with Parkinson's disease. Parkinson's disease is also said to affect 50% more people by the year of 2030, and it is also said to be more prevalent to occur in men compared to women, although the mortality rates are higher for women and the progression occurs faster in women. Risk factors for Parkinson's disease can be best described here. For example, genetic factors such as familial history of Parkinson's disease increases your chances of getting the disease. Also, there is greater prevalence the older you get. Early onset beginning at the age of 40 and more prevalence occurs after the age of 60 plus. Males are also more susceptible to getting Parkinson's disease. Also, having an exposure to pesticide increases your risk, and inhaling or consuming nitrogen dioxide in the air. Or if you have an experience with previous brain injuries that can put you at higher risk. And intake of caffeine and smoking puts you at a higher risk as well. The role of dopamine is essential to know when talking about Parkinson's disease, as well as when talking about regular physiological function. So let's begin. The essential role of dopamine itself is that it's an excitatory and inhibitory neurotransmitter that helps with precision in movement of the human body. So the role that dopamine is playing during regular physiological function is that it's an inhibitory and excitatory neurotransmitter. But during Parkinson's disease, it is affected by not being secreted as the dopaminergic neurons are either dead or destroyed. So ultimately, you have a depletion of dopamine, which is not good because if you look at the picture on the top right, it shows what happens when you have a depletion of dopamine. The dopamine is not getting to the receptors that it needs to get to. So when Parkinson's disease occurs, there is less stimulatory input coming to the cortex from the D2 receptor pathway, as well as when you have more inhibitory input coming from the D1 receptor pathway to the cortex. These are the two pathways that lack dopamine. Both lead to not having ultimate precision or controlled muscle function. So, for example, because of the impaired input that's going to the cortex to then the muscles, functional ability of the muscles decrease. There is now difficulty to contract the muscles, which is what essentially causes bradykinesia. The initiation of being able to move is now difficult because of the ultimate depletion of dopamine. That is why it is important to know what dopamine is for and what it does and what its role is and how essential it is in Parkinson's disease and regular physiological function. So now that we've discussed the role of dopamine, what it's for, how it's used, how is it essential in Parkinson's disease, and how Parkinson's disease arises through the depletion of dopamine, we should now discuss a little bit about where this Parkinson's disease is occurring. So let's talk a little bit about the anatomy and the physiology of where Parkinson's disease occurs. So we've already established that in Parkinson's disease, you have a depletion of dopamine that occurs through the degeneration of dopaminergic neurons, okay? So in your midbrain, that's where Parkinson's disease essentially kind of originates. It's a little broad to say that it originates there, but more specifically, you have your basal ganglia in your midbrain, and your basal ganglia consist of multiple structures, and one of them is your caudate striatum, which is made up of your caudate putamen and caudate nucleus. Now, your cortex, which is responsible for voluntary movement and initiation of those movements, that is connected to the basal ganglia via the caudate striatum, where input messages or signals are made. So now that we've talked about the input messages that are made from the cortex through wanting to have voluntary movement initiation, so this initiation of movement, voluntary movement, that is your input message. So now we have our output response from the basal ganglia through the globus pallidus, which is another structure in the basal ganglia. So let me repeat that. So you then have your output response from the basal ganglia through the globus pallidus internus that's connected to the thalamus. So the thalamus retrieves information from the globus pallidus, and then the information that the thalamus receives, that is sent to the cortex. Now the cortex then sends the message to the muscle on whether or not it should contract or relax. That message is sent down the spinal cord and to the muscle on whether or not it should contract. So in this slide, we're going to talk a little bit more about the physiology rather than the pathophysiology, but primarily we're going to make an overview of a little bit of the last slide to make sure we're on the right track before we essentially go through the pathophysiology of Parkinson's disease. So again, Parkinson's disease is ultimately caused by the degeneration of the dopaminergic neurons occurring in the substantia nigra, ultimately leading to a depletion of dopamine. So the substantia nigra is inside the basal ganglia, and the basal ganglia is inside the midbrain, and the basal ganglia consists of multiple structures. So the normal physiology of how messages and signals are sent through to the muscle for movement to occur, it happens like this. The cerebral cortex, in order to start or initiate movement, messages are sent to the basal ganglia. Then signals or messages from the basal ganglia are then sent back to the cerebral cortex through the thalamus. But I guess to be less confusing, the order could go like this. Or not go, but the order is like this essentially. So we have the cerebral cortex to start or initiate a movement, messages and signals are sent to the basal ganglia. Then from the basal ganglia, we go to the thalamus, and then from the thalamus back to the cerebral cortex. Then the cerebral cortex receives information from the thalamus, and then it sends these signals down to through the spinal cord and then to the muscles for movement to occur. So now that we've covered a little bit of the pattern of how messages are sent from the cerebral cortex to initiate movement down to the basal ganglia, from the basal ganglia to the thalamus, and then back to the cerebral cortex, and then from the cerebral cortex through the spinal cord, down to the spinal cord, and then to the muscle to either contract or have movement or not. Let's now talk about a little bit of physiological background right before we start talking about the pathophysiology. So once again, Parkinson's disease is ultimately caused by degeneration of the dopaminergic neurons occurring in the substantia nigra. So let's talk about the release of dopamine now in the regular physiological function. So dopamine is secreted into the caudate striatum, where it can bind to either D1 or D2 receptors. And if dopamine binds to D1 receptors, it has excitatory functions. Now, if dopamine binds to D2 receptors, it has inhibitory functions. Now, if dopamine is depleted, which is the cause of Parkinson's, it does not bind to either of the receptors, such as D1 or D2. Now, what happens with this depletion of dopamine, there is obviously a impairment of regular physiological function. So now we can move on to the pathophysiology of Parkinson's disease. So now that we've covered a little bit of the physiological background, the anatomy and the physiology of the midbrain and the basal ganglia, as well as talking about the role of dopamine and what it's for, and obviously what happens when you have a depletion of dopamine, correct? You have Parkinson's disease. So now in Parkinson's disease, for example, you have a depletion of dopamine. But the dopamine has two pathways known as the D1 receptor pathway and the D2 receptor pathway, correct? So now let's talk about what happens in Parkinson's disease with one of the two pathways. We'll cover one now and we'll cover the next in a different slide. So as dopamine is released initially by the dopaminergic neurons, it goes into both pathways, but now because of Parkinson's disease, you don't really have dopamine to be released. So now with the depletion of dopamine, the D2 receptor is not bound to by the dopamine, in which it initially was to inhibit a GABAergic neuron in the caudate striatum. So now you have no inhibition of the GABAergic neuron in the caudate striatum. That then results in less GABA being inhibited and more being produced, thus inhibiting another GABAergic neuron in the globus pallidus externus. So now we just talked about there also not being an inhibited GABAergic neuron. We just talked about there not being an inhibited GABAergic neuron in the caudate striatum. So now in that pathway of the D2 receptor from the caudate striatum, we go straight to the globus pallidus externus, where now, since there was no inhibition of the GABAergic neuron previously, you then have an excessive amount of GABA that then inhibits the next GABAergic neuron, which is in the globus pallidus externus. Because of that, we now have a result where the glutaminergic neuron in the third step of the pathway in the subthalamic nucleus is not inhibited, because we just inhibited the second one, and the second one was supposed to inhibit the third one. So now that we have the glutaminergic neuron in the subthalamic nucleus not being inhibited like it should have been, it now secretes a lot of glutamate, which then starts up another GABAergic neuron in the globus pallidus internus, the fourth step, and the fourth pathway of D2, the fourth step. So now that it starts up another GABAergic neuron in this globus pallidus internus, that results in an influx of inhibitory neurotransmitters being sent to the thalamus, which then communicates to the cortex and the muscles with inhibitory functions. So again, with this influx of inhibitory neurotransmitters from the thalamus to the cortex, we're essentially having inhibitory functions and messages and signals being sent, which results in an inhibitory function of the muscles to be able to contract properly or move properly. So that is the pathway of D2. So this photo is a visual representation of the basal ganglia and its connection with the cortex. So now this is a model that we can see on the bottom right that perfectly explains the dopamine release into each pathway of the D1 and D2. So as I previously described or talked about in the last slide, I talked about dopamine not being released by the dopaminergic neurons, obviously, because, we think of a patient that has Parkinson's disease. The dopamine is not being released by the dopaminergic neurons. So then when you think of the pathway of D2, there is no dopamine neurons to bind to the receptors. Thus, you don't have an inhibition of the GABAergic neuron in the caudate striatum. So then, because there is no inhibition of the GABAergic neuron in the caudate striatum, you then have an influx of GABA neurotransmitters inhibiting the next neuron in the globus pallidus externus. So now you have GABA inhibiting the GABAergic neuron in the globus pallidus externus, and that's not supposed to happen. But yes, and then you can imagine what happens next, as I previously described in the last slide, if you'd like to take some time to pause it and visually see what happens and look back at maybe notes that you've taken to see the pathway. So then after the GABAergic neuron in the globus pallidus externus, you have the glutaminergic neuron from the subthalamic nucleus that extends all the way to the globus pallidus internus to start up a GABAergic neuron in the globus pallidus internus that essentially has another influx of GABA, which then sends inhibitory neurotransmitters to the thalamus, which then is really bad because then you have an influx of inhibitory neurotransmitters such as GABA, destroying and stopping the pathway from the thalamus to the cortex, to then altering the function of the muscle to move. So that's essentially the D2 pathway described. In this slide, we will continue to talk about the pathophysiology for Parkinson's disease. In the previous two slides, we talked about the pathophysiology of Parkinson's disease and the depletion of dopamine and how it affected the D2 receptor pathway. So in this slide, we're going to talk about the D1 receptor pathway. Like the D2 receptor, the D1 receptor is also located on the caudate striatum. So the D1 receptor, because of Parkinson's disease occurring, is not bound to by dopamine, in which it was initially supposed to be, so it can excite the GABAergic neuron in the caudate striatum, so it can release GABA inhibitory neurotransmitters. But since that doesn't happen because of the depletion of dopamine, not allowing the D1 receptor to excite the GABAergic neuron in the caudate striatum, there is now no inhibition of the next GABAergic neuron in the next pathway known as the globus pallidus internus. So now the neuron is now active as it is connected to its next pathway, with it being ready to release GABA as it was not inhibited. So it's going to release GABA neurotransmitters that are inhibitory to the thalamus, because this GABAergic neuron was never inhibited by the GABAergic neuron in the caudate striatum that was supposed to be excited by dopamine, but because Parkinson's is occurring, you don't have dopamine, so then you can't excite the GABAergic neuron in the caudate striatum, which again leads to no inhibition of the next neuron in the globus pallidus internus. So now the neuron again is active and it's ready to release these GABA inhibitory neurons in its next pathway, the thalamus. So now the thalamus has inhibitory signals being sent to it along with inhibitory neurotransmitters, which means that its connection to the cerebral cortex in the brain is inhibited by these signals and neurotransmitters of the previous GABAergic neuron that was supposed to be inhibited, but it wasn't. Now the thalamus isn't allowed to send signals really to the brain, thus there is no ultimate movement of the muscle that's gonna happen. Like, you're not gonna see a contraction or relaxation or movement of the muscle because of the altered pathway of the thalamus talking to the cerebral cortex, because of the GABA neurotransmitters that are inhibitory, that are altering the pathway for communication. And that is the pathophysiology of Parkinson's for the D1 receptor pathway. In this slide is a visual representation of Parkinson's disease. On the right-hand side is a model of the basal ganglia and what happens in its normal physiological function. But if you can, please use your imagination so we can talk about what happens with Parkinson's disease and the D1 receptor. So on the left-hand side, you see your D1 receptor pathway, and on the right-hand side, you see your D2 receptor pathway. We already covered D2 receptor pathway, so now let's cover the D1 receptor pathway. So as Parkinson's disease occurs, we don't see a release of dopamine, so we have a depletion of dopamine. So now, because we have a depletion of dopamine, as you can see on your left-hand side, the dopamine, if there wasn't Parkinson's disease, would bind to the D1 receptor on the left-hand side on the caudate striatum. But because there is Parkinson's disease occurring, you wouldn't see dopamine bind to the D1 receptor on the caudate striatum. Then that means you wouldn't be able to excite the GABAergic neuron on the caudate striatum. And then because you can't excite the GABAergic neuron on the caudate striatum, that means that no GABA inhibitory neurotransmitters are released, thus allowing an active GABAergic neuron in the next pathway, which is the which is the globus pallidus internus. So you have a active GABAergic neuron on the globus pallidus internus because the previous GABAergic neuron wasn't excited to release GABA neurons. So then, as you have a active GABAergic neuron that shouldn't be active, it's now going to release its inhibitory neurotransmitters to its next pathway, the thalamus. Now, as the thalamus is the next pathway, it's now going to suffer from getting those influx of GABA neurotransmitters that are inhibitory, because now that's going to screw up the communication between the cerebral cortex and the thalamus, not allowing for ultimate function of the muscle to move. And that is the pathophysiology of the D1 receptor pathway for Parkinson's disease. In this slide, I will be covering the diagnosis of Parkinson's disease. So as of today, there is still no specific test for Parkinson's disease. To diagnose a patient with Parkinson's disease, diagnosis is based on clinical manifestations such as appearance of tremors, bradykinesia, which is the struggle to initiate body movement, loss of smell, your age. The older you are, the more prevalent you are to unfortunately get the disease, family history, genetic factors such as a possible gene mutation, postural instability, rigidity of the body, and stiffness. In this slide, I will cover the treatment of Parkinson's disease. There is no official treatment to cure Parkinson's disease as of today, but there are treatments such as therapeutic methods to help with the symptoms of the disease. Currently, the best methods for treatment are providing treatments to alleviate the symptoms the patient is experiencing. For example, minimizing symptoms such as dyskinesia, tremors, or even postural instability and body stiffness. In this slide, I will continue to talk about the treatments that are used to help with Parkinson's disease, starting with pharmacologic therapy, that is, using medications to help alleviate certain symptoms the patient is suffering from. Most medications are used to help with the symptoms that allows the patients to continue their daily living. These medications alleviate symptoms such as dyskinesia, nausea, dystonia, orthostatic hypotension, etc., but are not limited to, because different medications help with different symptoms. Some of the medications that are listed are levodopa carbidopa, levodopa benserazide. There are also dopamine agonists for motor symptoms, and there are beta blockers, which are also known to help with tremors. Lastly, I will cover the signs and symptoms that are associated with Parkinson's disease, starting with resting tremors, bradykinesia, which I talked about is the difficulty to initiate movement, loss of sense of smell, postural instability in a patient, speech impairment, and body stiffness and rigidity. There are definitely a ton of more, but these are just the most common ones. To conclude, these are my references that I used for my presentation known as Parkinson's disease, and I'd like to thank you all for watching, and I hope you learned something new.